This is a CT pulmonary angiogram, and the question is this pulmonary embolism? Evaluating the rest of the pulmonary arteries revealed no other areas suspected of pulmonary embolism. So when you look at such an abnormality, please do the following. Change the window in the same location to a lung window. And as you noted here, there's lots of motion artifact which led to the pseudo-filling defect. Remember, motion artifact is relatively common and may lead to what looks like a pulmonary embolus, so don't fall into that mistake. The question is, what is the diagnosis here and there? The right adnexal lesion is rounded and well-defined with a density that is similar to fat, and this is consistent with a right-sided ovarian dermoid. The left adnexal abnormality has a rim of hyperenhancement. This appearance is consistent with a corpus luteal cyst. This corpus luteal cyst is a functional cyst that remains after releasing an ovum. It may be seen in pregnant or in non-pregnant females. Please note that a corpus luteal cyst could mimic an ectopic pregnancy, so when seen, please go with the clinical information and the lab findings. Take a look at this chest x-ray and try to decide if you see an abnormality. Although the lungs, the heart, and the bones appear unremarkable, one of the hidden areas to look at is the trachea. Make sure that the tracheal air column is centralized. As you see here, the trachea is deviated to the right side, and this is most likely due to an enlarged thyroid. However, a differential diagnosis exists. This is the chest x-ray on the same patient after having left hemithyroidectomy, and you see the trachea is well centralized. Teaching point: always check the trachea as a hidden area on chest radiographs. The medial aspect of both lung apices demonstrate areas of reticulation and architectural distortion consistent with fibrosis. However, the distribution of the fibrosis is unusual since it involves both sides of the lungs, mainly medially and sparing the lateral aspects. What's unique about this appearance is that there is a clear demarcation between what's fibrotic and what's not fibrotic, almost a clear-cut line that separates both areas. This unique appearance is consistent with radiation fibrosis, where the radiation changes are defined by the port of which it was administered. This patient actually received radiation to the neck for metastatic lymph nodes from a primary gastric carcinoma. The teaching point is, when you see fibrosis that is confined by what looks like a port in a non-anatomical location, think about radiation changes. There's a lesion in the left adrenal gland. Compare this to a normal right adrenal gland that has a typical inverted V-shaped appearance. The left adrenal lesion is well defined and has low attenuation. The density of the lesion is similar to the density of fat. The presence of fat in a left adrenal abnormality is characteristic of a myelolipoma, which is a benign no-touch lesion. To explain the name of the lesion, the first part of the name is myelo, which comes from myeloid, since the lesion contains hematopoietic cells. The second part of the name, lipoma, is a result of the lesion containing fat components that are very similar to bone marrow fat. This is a chest x-ray on a young patient. How would you explain the linear opacities and lucencies that you see in the right paramediastinal region? One possible explanation for such an appearance would be pneumomediastinum. However, you don't see a similar appearance on the left side, and this extends in an unusual fashion into the lung. It's very important to notice that the abnormality extends outside of the hemithorax into the soft tissues. Looking at the lateral chest radiograph shows that the abnormality is extrinsic and located posteriorly. This is consistent with hair artifact. Removing hair and extrinsic material from the field of view is the responsibility of the technician. If that does not happen, be aware of this pitfall.